Good evening, EDIC Part 1 aspirants and our honorable faculty. Today's the class is about gastroenterology, emergencies and surgery, which would be conducted by Dr. Anirban Chowdhury. He is a director, professor and critical care expert at Department of Anesthesiology and Intensive Care at GB Pant Hospital, New Delhi. His area of interest are as follows: critical care, mechanical ventilation, sepsis, nutrition, research, and medical legal.
Okay, thank you very much. It's a pleasure interacting you after a long break to all the EDIC participants. And the subject for today's discussion is gastroenterological emergencies and surgery. If you go through the questions for the last 5 to 7 years, you will be able to clearly find the areas from which questions are usually picked up. And the options that are manifold, that is to answer one question, you have to know at least 3 or 4 subjects. So this is the interesting or the important part of this subject is that sometimes things are mixed up. That is 2 to 3 systems gets conglomerated in a single question. And therefore, this answering requires a thorough knowledge about those individual aspects. So we will discuss some questions and we will also try to figure out the background from which these questions are asked so that it becomes easier for us to solve other questions as well. Let us start with this A-type question. A 72-year-old female presents to the ER with a history of severe excruciating pain in the right iliac fossa. Clinical examination reveals a heart rate of 124 per minute and a blood pressure of 96/64 millimeter mercury. Systemic examination shows mild tenderness in the right iliac fossa. So please note that the patient is having severe excruciating abdominal pain in the right iliac fossa, but showing mild tenderness only. Laboratory examination shows a total WBC of 16,860, lactate of 1.2. She has a background medical history of hypertension, diabetes, ischemic heart disease with atrial fibrillation. She was taking epixaban 2.5 mg BD for non-valvular AF, which she had stopped for the past 2 weeks. Now the question is, what is the next best modality for diagnosis of her condition? The choices are colonoscopy, CT of the KUB region, CT angio of the abdomen, or CT abdomen with IV contrast. I can take 1 or 2 responses.
CT abdomen with IV contrast.
Okay, anyone else? What is your logic behind this answer?
Sir, in my opinion, it is amoebic liver abscess, and with contrast, it will get enhanced.
Any other option? Any other participant with any different viewpoint? Well, let me give you the answer. So the correct answer is C. It is CT angio of the abdomen. So whenever this question is put, I have told you that the patient is having excruciating pain in the right iliac fossa, but there is only mild tenderness. So acute mesenteric ischemia presents with severe abdominal pain, which is out of proportion to the clinical examination findings. You have to note it. And acute tenderness to palpation is a late presentation only after necrosis begins. So that is why we don't get tenderness. Elevated lactate and LDH levels are also late presentations. You can see that the lactate was 1.2 in this patient, so which is very much within the range. And CT angio is the preferred modality with a sensitivity of 93% and a specificity of 100% to diagnose this condition of acute mesenteric ischemia. So therefore, the answer here is C. And in such questions, you will have to look for the clinical findings that has been put before you, because a lot of clue you can be gathered from this. So just for the sake of your background information, it is good to know that majority of the times this ischemia has a component which is arterial. This can be either because of thrombosis, embolism, mixed atherosclerosis, vasculitis, or dissection. Of course, thrombosis is the commonest. Venous is much rarer, only 5 to 10%, because of the hypercoagulable state in hematological disorders, cancer, pregnancy, on patients with OC pills for long duration, or following inflammatory conditions like pancreatitis, or in malignant or neoplastic conditions. Even without being into hypercoagulable state, there can be venous thrombosis, and there can be ischemia. Besides these two, there can be a third variant, which is called NOMI, or non-occlusive mesenteric ischemia. So all the patients who present with shock in the ICU, they are vulnerable for non-occlusive mesenteric ischemia. This can account of hypovolemia, hypotension, etc., arrhythmias, etc. So that is also another component of the acute mesenteric ischemia. Sometimes there can be mixed cases which require surgical intervention, and these are usually in the form of hernias, valvulus, closed loop obstruction, etc. So with this background information, if you go through the clinical features, so this is one area from where questions are asked. Moving on to the second question. The probability of developing intestinal ischemia doesn't depend upon one of the following factors. The choices are hyperemia, adequacy of systemic perfusion and collateral circulation, number and caliber of the affected vessels, or duration of the ischemic insult. Again, question answer is, all the participants are free to unmute themselves and respond to the question by choosing the proper answer.
Hyperemia.
Anybody having any different sort of opinion? Here you are correct. The answer is hyperemia. So very clearly, you can, such questions, it is easy to answer because you can eliminate easily by exclusion. You know that adequacy of systemic perfusion and collateral circulation is something which is very important. The number and caliber of the affected vessels is important, because more the number and greater the caliber of the affected vessels, the more are the chances of intestinal ischemia, and so is the duration of ischemic insult. So hyperemia or an increased perfusion for any reason doesn't look like a factor which can cause intestinal ischemia, and therefore the correct answer is A. So this acute mesenteric ischemia usually occurs suddenly. So whenever in a question you find a history that there is a sudden onset, that has to be taken into consideration, because if there is a sudden onset of small intestinal hypoperfusion, which can be either due to occlusive or non-occlusive obstruction, then that is a hint that they want to ask about intestinal ischemia. So superior mesenteric artery or obstruction of the venous flows, like the superior and inferior mesenteric veins and the stem. So that is secondary, because we will have a lot of other questions which can point out to that. But this is the line of your thinking. Whenever this chart is very useful, if you can go through it in your leisure, you will be able to, the image will get imprinted in your mind, and then it becomes very easy for you to follow this logarithmic approach. If there is a severe abdominal pain suspected for acute mesenteric ischemia, you go for risk factor assessment, do the necessary lab tests, which includes D-dimer levels, lactic acid, WBC, side-by-side fluid resuscitation, antibiotics, nasogastric suction, correction of the electrolyte abnormalities will continue. Subject the patient for CT angiography. You can figure out whether it is a superior mesenteric artery emboli or superior mesenteric vein thrombosis or superior mesenteric artery obstruction or a NOMI. And it is a multidisciplinary team assessment, both the primary physician as well as the intensive care unit management team. So we will have to initiate anticoagulation with heparin. If the patient is hemodynamically normal with no peritonitis, then you have a live now approach, which may include laparoscopy or revascularization or transfer to a specialized center. Revascularization will again depend upon the presence or absence of bowel ischemia. In presence of bowel necrosis, we have to go for laparotomy. Otherwise, even laparoscopy may be preferred or maybe followed. Revascularization, endovascular approach is preferred if available. However, if the patient is hemodynamically unstable with or without peritonitis, then again, patient needs to be put up for a emergency laparotomy for a damage control surgery, possible revascularization and anticoagulation to follow. Now, this schematic diagram, if you get imprinted, then the line of approach of treating such patients becomes very easy, and you will be able to answer the questions with much more confidence. Next question. 70 years old alcoholic, chronic liver disease presented with altered sensorium with irritable disoriented grade 2 in the endoscopy in the emergency room. All of the following are true regarding the management of this patient, except the choices are: lactulose or lactilol have been shown to improve encephalopathy, but without mortality benefit. Prebiotics or probiotics have been useful along with disaccharides, which help modifying the intestinal flora with less ammonia absorption. Hyperkalemia and metabolic acidosis results in worsening of encephalopathy, which needs aggressive treatment. LOLA, that is L-ornithinyl aspartate, has been shown to increase the ammonia metabolism and may be useful. And L-carnitine or opioid antagonists or zinc have been experimental therapies. These are not routinely recommended. So all of the following are true regarding the management, except, again, the question is open to the house. You can give your choice.
Jangan situ boleh, di pinggir aja, nanti hancur. Itu sebelah kanan, pinggir. Bukan, itu bude, pinggir.
I think that is not the answer. No.
Sir, C, hyperkalemia and acidosis.
Hyperkalemia and acidosis results in worsening of encephalopathy. That is very much true. If you see the patients, then we definitely we tend to avoid this patients. We try to correct the metabolic acidosis. The correct answer here is B.
Yes, sir.
Because prebiotics or probiotics have been useful along, which helps in modifying. So this is something which is not true. So all the others are true, and therefore it is very important to figure out from here that all the other choices that have been enumerated here are part of the routine management, except B, because the cause which has been cited here is not correct, because prebiotics or probiotics does not modify the intestinal flora with less ammonia absorption. This is not a correct choice. So whenever you encounters patients questions of this kind, try to figure out which are the definitely correct answers, and then it will be easy for you to make out which among the rest is less likely to be correct. Next question. A 54-year-old female is admitted to the ICU with complaint of epigastric pain, nausea and vomiting for 3 days. She had a similar episode 15 days ago, which started after a heavy meal and lasted for a few hours. On her general examination, her temperature is 98.6 degrees Fahrenheit, heart rate is 128 per minute, BP is 110/70. Laboratory investigations reveal a hematocrit of 48%, kindly note this, WBC of 12,000, blood sugar of 190, serum BUN of 10, USG abdomen showed a bulky pancreas with a normal biliary tree. After 48 hours of fluid resuscitation, her hematocrit became 42, BUN was 14, arterial PO2 was 59 on room air. Which of the following parameters would indicate severity of her condition? The choices are the fall in hematocrit from 48% to 42%, or the rise in BUN from 10 to 14, or the blood glucose of 190 milligram per deciliter at admission, or the fourth choice, arterial PO2 of 59 millimeter of mercury on room air after 48 hours. Question is open to the house. You can give your choice.
B, sir, B.
Any other choice? Anyone else? Do you think that blood urea nitrogen is so important to assess the condition of the severity? It is not altered in any other conditions? The correct answer is here. In these questions, you have to answer, stick to the basics. The most important is the arterial PO2 of 59 millimeter of mercury on room air after 48 hours, because the arterial PO2 is a clear-cut indicator of oxygenation, and therefore its value after 48 hours of resuscitation is the most accurate predictor of the severity vis-a-vis the patient's condition at the time of admission. The clinical history, examination, and USG, they all support the diagnosis of acute severe pancreatitis. We have various scoring systems to assess the severity of acute pancreatitis, which includes the bedside index of severe, BICEP, the Apache 2, modified Ranson, CT severity index, and many. Of this, BICEP is the most accurate and least cumbersome, and modified Ranson is one of the most widely used. So you will have to know a little bit of each of those scoring systems, particularly when it comes to Ransons and the BICEP. BICEP BUN of greater than 25 is important. Impaired mental status, SIRS, age more than 60, and pleural effusion. Less than of 2 indicates 0 to 0.5% mortality. More than 3 score indicates 5 to 20% mortality. And a score of 2 indicates 2% mortality. So that way it is easy to remember. It is a little difficult to remember the Ranson score, but at least you know that what are the parameters that are important in admission and after 48 hours of admission. So here you can clearly see that the BUN increase of more than 5 milligram per deciliter is to be noted. That would be within the these values, if you just go through once or twice, you will be able to check them, and you will be able to correctly answer these questions, which pick up the variables from such charts. So these charts are important. You have to remember it. Again, in Ranson criteria, you will have to find this. There are slightly little differences between modified Ranson, that is for the biliary, as well as in original Ransons for alcoholic and other, both at admission and in 48 hours. Here you can see very clearly that in terms of age, here it is more than 55 years. In modified Ranson, it is more than 70 years. And likewise, if you see, come down to the fluid loss after 48 hours is more than 6 liters as against more than 4 liters. So this minor differences are there between modified Ranson and Ranson, and it is important. If you can remember it, then it will be easy for you, as well as in the BUN increase of more than 5 as against more than 2. So these are very subtle differences. If you can remember, probably you will be able to answer correctly the questions which picks up the variables from such criteria. Next question. A 66-year-old diabetic female presents to the casualty with a history of fever and 12 episodes of watery diarrhea for the past 2 days. On examination, she has marked hypovolemia with a systolic BP of 60 and a pulse of 140. She is fluid resuscitated and started on inotropes. Her past history includes hospitalization for septic arthritis 15 days ago, requiring prolonged antibiotic course, which was complicated by prolonged diarrhea. The microbiological examination includes a positive stool assay for glutamate dehydrogenase and toxin B. Now, what is recommended as an add-on therapy for reducing the recurrence of Clostridium difficile infection in this patient? The choices are actoxumab, infliximab, bezlotoxumab, and actoxumab plus bezlotoxumab. This is a bit difficult question, but in the context of Clostridium difficile, it is important for you to know because questions are being asked on Clostridium difficile on certain aspects. Yes, the question is open to the house. Any other choices? So bezlotoxumab is the correct. It is bezlotoxumab. C is the correct answer. C is bezlotoxumab. The D was actoxumab plus bezlotoxumab. This is not the correct answer. So these are the human monoclonal antibodies acting against Clostridium difficile toxins of A and B respectively. And here you can see clearly that the microbiological examination includes a positive stool assay for GDH and toxin B. Therefore, the answer should be bezlotoxumab. This was approved by FDA in 2016 to reduce the recurrence of Clostridium difficile infection in high-risk groups and in age more than 65 years. It is given along with the routine standard care, and it is not as a monotherapy. The addition of actoxumab to the regime did not improve the efficacy. So only when you get a hint into the question that toxin was able to hide both A and B, then probably the choice will be there. You have to give the choice. Otherwise, the choice would be bezlotoxumab. And of course, fecal microbial transplant is an alternative strategy for reducing recurrences. And this question can also be put in some other format in relation to Clostridium difficile. This chart is very important. If you can go through once, it will help you to give a little bit of spreaded knowledge, superficially spreaded knowledge about those individual therapies, whether it is actoxumab or bezlotoxumab or IVIG, as against the oral application routes of IG, albumin, CDF, and etc., because their mode of action is slightly different. Whether they prevents binding to a cognate receptor, as in case of actoxumab or bezlotoxumab, or to the neutralization of other Clostridium difficile toxins, which is in IVIG, and this binding actions to the vegetative bacterial cells. So these minor differences are there, but these are very important, particularly in relation to recurrent Clostridium difficile infection. Moving on to the next question. As per revised Atlanta criteria 2012, for the diagnosing acute pancreatitis, the following parameters are used. So this is a K-type question, so you have to accordingly answer. Serum amylase levels more than 3 times than the upper limit of normal. Clinical examination consistent with acute pancreatitis. Radiological findings consistent with acute pancreatitis. Serum lipase more than 3 times the upper limit of normal. Question is open to the house. You have to say with yes, no, yes, yes, or true, true, false, false, something of that kind. All of these are true. So serum amylase levels more than 3 times, clinical examination, radiologic, both should be consistent, lipase levels. So this is a all true response. If you go through the Atlanta classification, you have to figure out that as against mild acute pancreatitis and severe pancreatitis, at least one criteria should be present, which may include any of the following. So this can also be picked up to frame a question, because there are multiple factors available and one of them can be twisted. Like pancreatic necrosis can be more than 30%. They may just change that A and make it less than 30%. Or systolic blood pressure 90 they may show as 100 or something of that kind. So this is an important chart you can have to understand. And the revised Atlanta criteria requires at least 2 of the following 3. So you will have to remember that serum amylase or lipase levels more than 3 times the upper limit, clinical examination and radiological examination, both should be consistent with acute pancreatitis. Now, on that basis of revised Atlanta criteria for acute pancreatitis, it can be categorized into mild, moderate, and severe. This is also a very important chart. Questions can be made framed from the basis on this chart. So what are the criteria in mild? What are the criteria in moderate? And what are the criteria in severe? Always remember that in severe, the persistent organ failure of more than 48 hours duration, whereas in moderate, it will be transient organ failure of less than equal to 48 hours, or there are local complications or exacerbation of comorbid disease. In the milder variety, of course, there are no systemic complications, no local complications, no organ failure, and typically they're much better because they resolve within the first week. Now, this division based upon revised Atlanta criteria is very important whenever you have to answer question on acute pancreatitis.